Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Joining me today is Dr. Jeff Barry, and I'm really pleased to welcome him to the show. Jeff is an orthopedic surgeon at UCSF, where he directs the Hip and Knee Arthroplasty Fellowship and co-directs the Arthroplasty for the Modern Surgeon course held up in Napa in August of 2026. His practice centers on adult hip and knee reconstruction with particular expertise in anterior approach hip replacement, as well as complex revision surgery, which makes him exactly the right person to have on for an episode like this one. Jeff, thanks so much for coming on the AHF podcast, and welcome to Operation FUBAR.
Thanks so much for having me. I guess it's an honor to be here for this, but we'll see if you agree after we go through these cases.
So you have a case prepared for us, is that right?
Yeah, it's a patient prepared for you. It's actually two cases. So
all right, perfect. Well, let's get right into it. Here we go.
Yeah, so I called this one "Please Don't Be So Nice to Me" because it kind of goes with a theme that I think as surgeons we kind of find that the nicest patients are often the ones that have the worst outcomes, and if you happen to be an asshole, somehow you're protected against the bad things happening. So this is a very nice patient.
I think a lot of surgeons can relate to that for sure.
Yeah, a little foreboding. So this is a 75-year-old, also a retired nurse, which is another bad predictor being in healthcare. She lives alone. Her daughter accompanies her to visits. She is the nicest woman in the world. And was having hip pain for 2 years, worse over the last 4 months. So previously gardened, did her own shopping. Now she's limited mostly to a wheelchair, walker for very short distances, but eyeballs very frail. So definitely, older than stated age in terms of appearance. She has leukemia with very low platelets. Osteoporosis that's gone through Evenity treatment. CHS uses O2 at night. And has kind of a scattering of medical comorbidities. So, just right off the bat, kind of a less healthy patient, not one that we're not used to here at UCSF. Like we get a lot of patients like this, but, you kind of temper your expectations right off the beginning, right off the bat. And these were her x-rays. So she came with two sets of x-rays, one that she had for her referral, and then the ones that we got in our clinic. And you can see just in a couple months how this hip has progressed on the right side, that, femoral head has collapsed. You can see some generalized osteopenia, osteoporosis, but, fairly straightforward surgical indication for this one.
And this is a 6-month time frame between those two images. Is that right?
Exactly.
Okay.
So I met her in February. So that's the one on the right there. And this is a very, she started having pain years ago, but really acutely started in that August-ish period, and then came to me in February with a collapsed head.
Okay.
So this was our plan for her, in these kind of collapse cases or sick patients. I kind of treat this like a femoral neck fracture patient. So I'm going to do it on HANA table. I almost always do a full femoral release just right off the bat whenever I'm exposing these patients. I know that ahead of time. I'm going to be really aggressive in that to avoid undue tension on the troch or other parts of the femur. We're going to do a hybrid fixation. We're going to cement the stem and use a press fit socket. And I'm going to talk to anesthesia ahead of time about kind of cement and what the risks of that are. Make sure that they're aware of, keep the O2 all the way up, be a little more aggressive on the fluids. And then for this patient, they got really low platelets. We're going to make sure we got platelets available if we need to transfuse and just kind of be set up for the surgery. But this is going on a regular OR day. I'm usually running 2 rooms. This is the hip, so it's earlier in the day. Just kind of slotting into the schedule like normal. But being a little more careful just because we know the bone's not going to be great.
And did you talk with her about time in the hospital as well? Is this something that you would send home the same day? Is this something that you'd plan to keep in the hospital? What are your thoughts on that?
Yeah, this is definitely someone we're going to keep overnight. Someone on O2 at night, someone we're going to cement low platelets. We're maybe a little worried about bleeding afterwards. We're going to just keep an eye on her. She also lives by herself. She has family available, but that's not someone that in our shop we're sending home the same day. So she's aware of that and aware of the risks. You talk about everything with these patients, especially the lung risks were actually probably our biggest discussion. Someone on O2 at night, going to go through a necessary cemented hip. That's the bulk of our risk discussion more than anything. Yeah, so we do the case. Starts off fine. We do our cup. No issues there. And then this is kind of how I normally will position a femur. So this isn't this case, but just a video I made for the residents that has our entire procedure. So I use a hook. I use a femoral hook. I'll rotate out to 120 degrees on the HANA table. Make sure that kind of the medial calcar is clear of any soft tissue attachments. Put a medial retractor and kind of use that to lateralize the femur a little bit. And then I'll use the hook to kind of lift up and make sure we're keeping things away from getting stuck behind the pelvis as you go down and under with traction off. So that's kind of my normal workflow. I think that's probably how a lot of people with a HANA table would do that initial femoral exposure or leg over and under. And so in this case, we put the hook in, we rotate the leg out, we go down and under. And I don't hear anything. I don't see anything weird happen. But then when I go to look at the femur, all I'm staring at is a tube. Like the entire top half of the femur just sheared right off in the going down and under of the hip.
Wow.
So this is like, I was just, oh shit, like where'd the rest of the femur go, right? And so, this is, it's just stayed right where it was. I'm kind of like feeling around, like I'd done my full capsule release, which I normally do. I keep the capsular flaps, I tag them. I've taken that off the top before I go down and under. I don't usually do the conjoint or the piriformis release until it's down and under. And that's how I've done it for thousands of cases. This is the first one where it decided to not cooperate here. And so as I'm exposing this and looking at it, I'm like starting to check the bone a little bit better. I knew it was bad when I made the femoral net cut, but this is where it's like, this is really, really bad bone. When you're pushing on the cortical bone, you can see it flexing on the anterior and the posterior of the proximal femur. You're just staring at this open tube. And I try to show kind of what I didn't have a great x-ray, obviously, or picture intraop, but this is kind of where that looked like. You'd have a femoral net cut and the whole top of the troch just kind of comes off. I've definitely had like little tip avulsions, things like that over the years of the trochanter doing DA, but this is like the entire troch below the vastus ridge, just straight off and down.
Wow.
Yeah. And so this is kind of like, I kind of think of the response to trauma for a surgeon as either the Michael Jordan response or the Chris Farley response. One is you can either like, some people just freeze up and they just start kind of crying on the inside. That's the Jordan meme response. Or I'm kind of more of the latter, which is the Chris Farley response of just like, what the, just I have to like, I just get really a little bit upset and mostly at myself, right? Like you feel like you've done something that created this when in reality, this is like, this bone, you'll find in a second, this bone is horrible. But it's kind of like, what do you do next? How are you going to process this? Everyone has some sort of initial internal response, and how are you then gonna move forward from it? I think is part of surgery and kind of just you learn yourself and how you're going to move forward.
Well, and is your team seeing Chris Farley, or are they seeing Michael Jordan, or are they seeing somebody else?
I hope Chris Farley's mostly on the inside. I think I definitely let it out a little bit sometimes. My helmet in the OR, we have our names on them. Like we all have our own helmets, and mine has a little fire next to it, like a flame. So there's definitely a little bit. I'll blame my hair color on that one, but yeah, there's a little bit of a Chris Farley. But I think like it's important that once this happens, you do have to take a step back and be like, okay, what the hell are we gonna do next? And so like one of my attendings in training would always like say, if you have something go wrong, like put a lap in the wound, turn around, go to the back table, like do whatever you have to say to yourself in your head, and then just kind of list out what the options are and what you should do next. So for me, it's kind of like, are we just going to keep going? Like, just leave the troch where it is? Are we going to abort and change things? Are we going to call for a troch plate and try to fix this thing? And at the same time, in the back of my mind, I'm thinking about the frailty of this patient, that, like, they got no platelets. They're kind of oozy the whole case. Their BMI is 18. They're probably malnourished and kind of very frail. I'm about to throw cement into them in a pulmonary patient. So, all this is kind of going through my mind. So we decided to proceed with a cemented stem. I kind of just used that tube and cemented into it. You can kind of see this is an intraop film. You can see how bad that bone is up top. You can't really even see what's going on up there. But we just left the troch where it was. I didn't trial because I didn't want to break the femur further. And this x-ray is really deceiving in the cortical thickness there, but you'll see later kind of what the bone quality actually was. And I kind of went with less is more here. So, the abductor sleeve was still intact. The bone is so bad that even if I put screws in it, I don't think it's going to hold. Yeah. And I took a bunch of that femur, sent it to Path just to be sure I wasn't doing something or getting into something really weird. And we just cemented in. So, this is the PACU, and no one will know the struggle, right? Right. This is one of those cases where you talk to your buddies, like, look at this case I just did. Like, this was crazy. Like, the troch just was gone. The bone was horrible. All my retractors are pushing through the bone, and like it looks like a cemented hip. I don't know what you're talking about. But this was, a mess on this side. And this is the PACU x-ray. We slowed her down a little bit, how to use a walker. I knew the troch was off. She's low demand. I let her go. And at 4 weeks, this is what she looks like. You can kind of see that troch missing a little bit in the cement over there. And at 4 months, on a lateral, the troch's actually moving with it. Like, it's kind of moving as a unit. Like, she's walking with a walker. She's super, super happy and just so grateful. And like, oh, this is great. When in reality, like, intraop, this is one where you're staring at this hole and you're like, I don't know what I'm going to do here.
So let me ask you, at this point, are you feeling like, man, I am pretty damn good that I got this? Or was this I can't believe I slipped by on based on everything I saw?
Yeah, this is a like Neo in the Matrix moment where you feel like you dodged the bullet, and you're kind of like, woof, got lucky on that one. And, it like in the moment, I think you get a little bit hung up on like, what's going to happen here. But if you just kind of work through step by step, things go okay. And, this is, every surgeon has these cases where like you're trying to describe what happened to drop and the x-rays don't really match up. You're like, this doesn't look that crazy. But when things are so bad or the bone is so bad, you feel very humbled at how bad bone can get, I guess, is what I'm trying to say. So this side was arguably like, this was a little bit stressful, the side, but she did really well. And
I would imagine much happier than having a rapidly progressive osteoarthritic hip, right?
Yeah, exactly. And she, went from pretty independent to a wheelchair, and now she's back to fairly independent. So very happy in the whole. After the surgery, I sent her to get a DEXA scan, and this is the scores that she got on her other femur. So her left femur had a T-score of minus 5.1. And so like just to review kind of what T-scores are, T-score is a standard deviation below normal bone. So 5.1 standard deviations below normal. And you're like, 5, that's not so much. But if you think about how a normal distributed standard deviation is, 5.1 is actually 1 in 6 million. So in the SF Bay Area, there's like a population of 7.6. This patient's from a little farther away, but still gets to the point of like, this is horrendous bone. And I don't know why the x-ray doesn't show, but it looks bad, but it's not the worst bone I've seen. But this bone density test is really showing that, hey, this is horrible bone. And so, Bill Griffin, who was one of my mentors in fellowship at Ortho Carolina, used to say all patients are like satellites. You launch them out into space, and eventually they're all going to kind of come back out of orbit. It's just a matter of when. And so, yeah. So the enemy of good outcomes is follow up. And this patient comes back a year later, and this is this is one of those ones that you see on the schedule and it says just, follow up hip pain. And you're just like, oh crap. Like what is this going to be?
Oh no.
So she's back in a wheelchair and she says, I haven't been able to walk for 3 months, but she says it's her left hip that hurts. And so you're like, okay, we got it. So looking at this film and being able to compare to others, she actually has a missed femoral neck fracture. So she was diagnosed, she lives kind of in the boonies and was diagnosed with just hip pain and arthritis and sent back to us to get evaluated. But she's actually had a femoral neck fracture, kind of a valgus impacted femoral neck fracture for the last 3 months. You can kind of see in that inferior cortical area on there that it's definitely off and kind of shifted down. So again, this is one that, are like, okay, round 2, here we go. We're going to do this again. And I got, this time we're going to be ready. We get the whole game plan together. We're going to use a multi-hole cup right off the bat because we know the socket bone's going to be bad. Maybe we need some extra screws. This time I'm not going to break the troch off. So it's not my normal workflow, but before I even drop the leg down, I'm going to do all the femoral releases, like no stress on the trochanter. We know we're not going to trial the cemented stem, so I got to get that neck cut good right off the bat. And I'm just going to be careful every single step of the way. And I'm going to make sure we got everything in the hospital in case we need to do something weird. Okay. So this is the game plan. This is as we're getting ready to hit the cup in. I ream and hit the cup in under fluoro, and going to my 90s movies and things. It's wide open. All you got to do is tap it in. Just tap it in nice and gently. I'm walking the resident or the fellow, like, I'm gonna hit this one in. Just hit it nice and gently. Just tap it in. All right, tap it in. Little tap, tip tappy, taparoo. God dang it. And this is like, you're like, shit. Cup goes straight in the pelvis. And so this is pretty common thing, I think, for us as surgeons, is like, we know we're worried about a certain part of a case, right? There's going to be a complicated part of the case. And this one is like the femur. Like, most of my thought is on the femur. Yeah. I know that's going to be tough. The bone's bad. DEXA's -5. This is a 1 in 6 million crap bone. And then I wasn't totally distracted. Like, I knew it was going to be bad. I'm being gentle, and still something happens on the other side. Yeah. And so then you're just like, you're very much, in the, like, I'm the, God dang it, like, what the heck? I swear I'm a good surgeon usually. But yeah, this is like one of those ones. And now you're back to this kind of Jordan or Farley response or Happy Gilmore response. And you got to take a step back and be like, okay, what am I going to do now? Like, this is bad bone. I just put a revision cup. I was using a multi-hole cup. Like, I was being gentle, and it just went straight in. So, I'm thinking through my options. Like, do I want to do a different cup? Do I need to do like kind of a tumor style rebar screws and cemented cup? I do that not infrequently for some metastatic cancer stuff. Do I want to come back another day? Do I want to put a cage in or cement a cage in? Do I want a cup cage? Like what do I do? Okay. And again, in the back of my mind, I got this medical frailty and this kind of not super healthy patient. And I still have to do the cemented femur, which I was worried about to begin with, right? So you got all these things swirling. I try to assess the defect, which you can tell from this X-ray is really easy to see. The bone is so bad. But it seemed like the anterior column was out and the medial wall had kind of blown through, but my posterior column was still intact. So, that I do a ton of revisions like that. That problem I can do. I got a column intact. I got some pinch I can get from the ischium to the ilium. I can figure this one out. We were able to take a multi-hole revision cup, go bigger. I didn't ream. I kind of under ream by probably, I think it was like 4 millimeters in this one. Just kind of tap a revision cup in there. Still soft as hell. And I love locking screws in revision cups. This cup has locking screws, and I just filled it up like a Sputnik. I tell the fellows, it's like, just put the screws everywhere. Even if it's a 15 screw that's like, 2 millimeters of cortical bone, put it in, use it as a stud out of this Sputnik cup, and just get as much fixation as you possibly can in every position.
Yeah.
From the DA, like, it's really nice to be able to check all these screws too, make sure they're not like egregious, but a bunch of these are not really in that good a bone, but I'm putting it wherever the screw hole was. And you can see from that first x-ray to the second one, like, I kind of rotated the cup a little better to get where some bone was. And yeah, this is still a sinking feeling when every time you put the depth gauge in, it just kind of goes, and you have no idea. Like, it'll just go right through the cortical bone, and you're just like,
Right.
what? You have to use C-arm almost to see where your screws are. But lock it up. Locking screws. This is kind of like an internal cage in my mind. Is like, I think these locking cups can take away the need for a cage in some situations, because it is kind of this fixed angle device in all directions. So that's what I did on a cup. This is one where, when you're using C-arm a lot, you get kind of these funky things. And if you look at the pubic area here, like, I haven't touched anything. I just kind of moved the C-arm a little bit. It looks like this thing's moving all over the place, but it's just because those screws aren't actually in the pubis. They're kind of like in front or behind. And so it looks like it's a mess, but it seemed to have good fixation. I was able to kind of grab it, shake it with a coker, wasn't falling out. So I'm okay with that and moving forward.
Yeah.
These are our PACU films. I put on 50% weight bearing for a bit. I hate to limit people after primary, but this bone necessitates that. Let it grow in a little bit. We actually got away with the femur, no problems this time, right? So we did all the releases. We're worried about stuff. We got away with the femur and no issues. But
of course,
yeah, of course. But the cup was definitely a little bit of a nightmare. So this is her at 3 months. She's walking again. She's more limited by her pulmonary function actually than things, and she's very happy. Both times she had to go to the ICU post-op. I didn't really go to that very much, but her blood pressures were just low. It was a long case. Like, we didn't take that long. Like, this kind of salvage stuff didn't take that long. But just with an O2 requirement and at baseline and kind of wanting to watch her, they sent her to ICU for short term. But she's a nurse. She knows what happened. She knows this isn't kind of like plan A, but still like the nicest and happiest patient. So, I'm seeing her again, I think, in a couple of weeks for her 7 month or 8 months, something like that. But hopefully seems like she's doing well. I can see PT notes, and she's still walking around and doing everything. So
yeah,
hopefully no
she's not
satellite
showing up
crashes.
For hip pain at the clinic. Can you go back to that previous one? And maybe it's the quality of this. Yeah, that one right there. Maybe it's the quality of this x-ray, but you had remarked earlier, at least on the right-hand side, about, there was that intraoperative film where her diaphyseal cortical, thickness appeared pretty reasonable. It seems to be much less reasonable looking on this x-ray, and maybe it's a projection, or it's something about how they took the image issue. But at least on the right side, the diaphyseal cortical bone is now starting to look kind of a little moth-eaten. I mean, it looks pretty irregular.
It kind of looks
right?
like that on both sides actually, and
Yeah.
I think it really is just it is technique or films. This was done at one of our satellite clinics, so the films there are a little funky, but yeah, I think that clinic to clinic, like, you get used to what your clinical films look like, and
Yeah.
kind of that often gives you a better sense of like what the bone quality is, because you're used to seeing your gating, your exposure. And so I think when we get these films from outside hospitals that have been gated funky or changed, it definitely will throw you off. And that's where I think, like, in this situation, the DEXA is the objective, like, density test. Like, I think I have a good eye for like Dorsey, and kind of I try to plan ahead when I'm going to cement, but this was a little bit of an eye-opening one of like, hey, this x-ray looks okay, but I'm pushing on it and it's bending. Like, maybe there's some pathologic metabolic process going on here.
Yeah.
I don't know what it is, but this is different. And the DEXA seem more in line with what we're seeing than the plain films, for sure.
Well, I think we're going to have to call that the Barry test from now on, right? If femoral cortical bone flexes with pressing. That's a
Yeah,
positive
exactly,
Barry sign.
exactly. I thought it was interesting to bring up, and this in my mind was a very similar case, but I had a different role in this one, and I thought I'd bring this up just because, like, when we're in the heat of the moment and we are the primary surgeon, it's often very hard to distance yourself from what just happened and get some clarity and thinking. And this was one that um, I was not the primary surgeon. I had a different role in this one, and I think it just it speaks to, or hopefully I can speak to, kind of the processy differences that at least went through my head. So this is one that had a femoral neck fracture. One of the fellows was on call, and this was their case to take care of. They also had a distal femoral non-union below it with a nail, and so to treat the femoral neck fracture, that retrograde nail had to be switched to a short nail. The trauma team also put a plate on, and then they were going to do this total for a femoral neck fracture. And so the fellows, by the time they got to the part of doing the hip, they're the only surgeon in the hospital from the arthroplasty perspective. They go to put a cup in, and they didn't get good serum shots, but they actually created a discontinuity putting the cup in. So the whole pelvis discontinuous, like fracture all the way across, and again, this is a renal patient. You can tell this is a little more, apparent on the x-ray how bad the bone is. But this is one where, at 9:30 at night, I had a call from the fellow and was like, hey, can you come help us? Right. And so this is a little different. Like, this is, I get to come in on my white horse. I have time to think about things. Like, I'm kind of game planning. It's like, okay, just cement the femur. I'll be there. We'll help you fix the socket. And so I think that these types of situations where you have a second to step back and really think about, like, okay, what's my plan? Like, I'm going to ask for this, and this. Like, I'm going to be the quarterback as soon as I walk in. Like, tell circulator, get this, rep, get this, scrub, get this ready. I think things go a lot smoother than when you're doing the Chris Farley and, like, okay, give me this. Actually, I want this, and, like, call for that, and, like, things are just scatterbrained. And if you have that second to really just plan ahead, direct traffic, let everyone know what's going on and kind of what you need to be successful, the thing goes a lot smoother. And so in this situation, we actually were able to do a cup cage really quick. So I think this took like 35 minutes from the time I scrubbed in to the time I was finished with the cup. And everything was ready because I had called in and asked for it and said, have this there. I'm going to do this, this, and this, have the cement ready for the inner cup. And we're able to just kind of slam this thing in really quickly. A different scenario than the last one. Both columns are out. It's not something I'm going to just rely on a few locking screws inferiorly. But, this is a very similar problem intra-op, but with a very different workflow in terms of how we got to the same outcome. But yeah, just thought that was interesting. So, my takeaways from this case are bad bone can get really bad, and a -5 standard deviation is really rare. And then beware of the trap side, right? So you think of sports, there's like the trap game where you got the big game you're thinking about and some nothing ahead of it. It's the cup and a femoral neck fracture. It's the femur and a DDH case with a Crow 403. It's that other side that you get blindsided by. And then the less is more, or less can be more thing is a predominant theme. And, this is a patient who you always hear run towards your complications. Like, I was rounding on this person every day. You send them more messages. You see them more frequently post-op. You give them more time every time. And, that's how you take care of these patients. But, just tongue in cheek, like, nice disposition risk factor, healthcare provider risk factor, follow-up risk factor, right? All these things are troublesome. Yeah.
Well, Jeff, that's a great case. And I have a question for you, based on that second case that you showed where you get to be, riding on the white horse, right? You get to be the hero. If you envision your role in that scenario where it wasn't your case to begin with, and you didn't have to be sitting at home thinking about it, planning it, you got to come in and got your head straight. When you find yourself in the next version of this nurse's case, right? Are you going to be thinking to yourself, how can I be my own hero on a white horse? Or are you going to be thinking, who do I need to call to be my hero on a white horse? Meaning, is this something you want to grow within yourself? Or is one of the messages to learn to rely on others and what they can bring to a challenging situation?
Yeah, I think that's a really good question. I mean, I think that, the skill set for surgeons that do a lot of revisions like myself is definitely there to take care of any of these problems, but sometimes the mental clarity aspect is not there when you're in the moment. And I do ton of customs, ton of cup cages, ton of all these like big things. But definitely there have been instances where it might not even be an arthroplasty surgeon. It may be a trauma surgeon in the room next door that you're just like, hey, can you come over here and can I just bounce something off of you? Or can you just look at this and like tell me whatever you comes to your mind? Like, just give me another reasonable person to talk to here. If you're with an R2 like that, that's not a great sounding board, right? Like a second year resident is not a great person to be like, hey, what do you think?
Yeah.
What should we do here?
Yeah.
Sometimes the fellows are actually very helpful, and especially early in my practice, like I actually loved bouncing stuff off the fellows because they're very close to you, and it's like in terms of your training and experience wise, and it's like, hey, what should we do? Like, what do we come up with? How do we MacGyver this thing back together? Um, Now hopefully 8 years into practice, I am a little bit better at kind of stepping back and kind of thinking and be like, okay, luckily, these primaries, these are few and far between where these issues happen. But, in revisions, you get used to being caught off guard by, hey, that's not what I was expecting, or, hey, this, femur just cracked or whatever. So I think the more revisions you do, the more used to it you get for the troubles in primaries. But the most humbling are the straightforward cases, right, that have trouble. I don't expect a primary hip to have trouble, and so when it does, those hit the hardest, and those are like, okay, you definitely play back that one in your head a few times that evening.
Well, and that was going to be one of my questions is, you're used to these revisions. You've got a revision mindset, certainly when you're going into revision cases. And is this an issue of bringing that revision mindset to primaries so you don't ever get caught off guard? That's also got to be kind of exhausting, right? Because, revisions, while they can be exhilarating, putting that amount of time and energy and effort and thought and worry to a certain extent into every primary has got to be that's got to be just as exhausting, if not more so.
Yeah, I don't think that's necessarily a sustainable practice, but I think that all of us are creatures of habit, and we have our workflows, right? And if you have a workflow that is complication avoidant, right? So like certain steps, are maybe a little more dangerous, and you're kind of verbalizing that. And at least in my setting, I'm teaching, and so teaching fellows and residents, and you're looking for the problems before they happen. I think that is avoidance is better than trying to fix it later. And so, for these situations, this case, we learn from our last whatever number of cases, right? Those are the ones that stick in our mind. So, but certain things will stick with you, and they will become new stepwise things you take forward. So, for example, in this now, I do the femoral releases of the conjoint and the piriformis now for a lot of the femoral necks and for the really bad fractures, so that I don't pull that troch off, or this doesn't happen again on the troch, which didn't used to be my normal workflow. It's a little harder to do it when the femur is not down and under, but if it takes another 30 seconds and then those bad bone patients, that might be what's needed.
So the one other question I was going to ask you is, obviously you do have learners, you have fellows with you, you have residents with you, and clearly you took something educationally away from this case. Do you think the learners who were there with you took those same lessons? Did they take different lessons? What do you think they took away?
Yeah, I mean, you'd have to ask them, obviously. I mean, we kind of we discuss kind of what's going on, and I'm sure they see the stress in the attending surgeon when things are going wrong. So I think that when I was a trainee anyway, and I was seeing tough problems, like I always took away kind of what their thought process was, or what are they thinking. Or I would, you don't ask them in the moment. That's a very dangerous move as a trainee. But you kind of see like, what is their workflow? Did they step to the back table and kind of think about stuff? Did they suddenly start to find the need to irrigate for another minute or two? Did they kind of just go somewhere else, go to the femur and come back to the socket, or like what was their workflow? And I've kind of tried all those through the course of practice, and I think I've come to my own response strategy, which is, I kind of am more of the put the thing in the wound, turn around for a second, like just game plan. What do we have open? What are my options? Pick one, and then what do I need? Communicate with the scrub, communicate with the circulator, like, hey, shit just hit the fan. Like, let's turn down the EDM music for just a little bit, and kind of we're going to focus a little bit more for a second. Like, this is not a typical primary anymore. I need your help. And then go back to fixing the problem. And I think that's been the best way for me to kind of just recenter, get the blood pressure back down, and go at the problem at hand. And then you get into revision mode, you get into normal, like, fix the problem mode, and it's just another case.
And was this a communication issue with the anesthesiologist as well? Obviously, given the frailty of the patient, was that also part of your communication strategy?
Yeah, for sure. I think that you got to be communicative with the other side of the drape for these sick patients. And it's like, hey, I just, for the cup one, for example, it's like, hey, I just added probably another 20, 30 minutes to this case, just letting you know, like, it's going to bleed a little bit until I get a liner back into this socket. And you might want to have, if we didn't have the platelets in the room already, like, maybe call for that stuff. If we didn't cross for some blood, make sure you got that. And then, for the femurs on these patients, I am super cautious about cementing femurs. I will tell them at the timeout, like, that's part of the timeout when we're going to cement, like, hey, we're going to cement, whatever anesthesia intern is on the other side of the thing. Like, please keep the oxygen at 100, like, run fluids a little higher. Like, I know they might have to pee or get capped afterwards, but let's not kill them from cement syndrome. So, that's something that's already in my workflow. Luckily, that hasn't been something I've experienced, but if I cement enough, I'm sure it will. But yeah.
One last question, because at least the first side you indicated was on a normal primary total hip day. And I don't know if it was first case, I don't know if it was last case or somewhere in the middle, but assuming it wasn't the last case of the day, and maybe it was, how does that affect, not just your workflow, right? Your timing, because you're used to setting aside a certain amount of time for a primary, and if you're going back and forth between two rooms, but how do you take that into the next room, or how do you not take that into the next room?
Yeah, that's a really good point. Yeah, I do. That was kind of middle of the day, maybe second or third case of the day. We run two rooms and have multiple cases after that. I am not an overlapper, so I don't let other people start a case while I'm in a different room. So that aspect of the stress is not there. Like, I didn't have another patient under anesthesia yet. It's not something where I have to worry about that. And that's part of the reason I don't overlap ever. It's allowed in our hospital with a fellow who's helping you or another attending on backup, but that should not come into it where I'm going to rush something because another patient's already under anesthesia or already gotten their spinal, and that's kind of ticking. So luckily that's a decision I made a long time ago, that I'm just like, I don't want to deal with that added aspect of things. I don't know how surgeons who do that and they're in one room and kind of another room's going, like, I'm way too much of a control freak to give away that to a trainee. But the like, bringing it to the next case is totally a hard thing to do. It's impossible not to have it somewhere in the back of your mind, right? Like, you definitely have to take a second to take a deep breath, though, and, like, in between the cases, like, do whatever you got to do. Like, go get a glass of water, like, take a second to go get a snack downstairs. Like, for me, it's just like, I kind of will just sit down and kind of look at what happened, and I like to debrief myself and kind of go through, like, what could I have changed? Was it an avoidable thing that I made a mistake, or was this kind of hey, this is just a bad situation that something was going to happen? And I think a lot of times our ego is able to be like, okay, that was something that was probably, not 100% your fault. Like, there's some other stuff there. Like, you do these things like you do like a crow 4 or something, right? Like that's like a 25% major complication risk. If that has a complication, you can't beat yourself up over that. Like certain things are going to happen. You do your best, you try to learn from them, but there's a certain risk that is just inherent to the procedure. So you have to kind of keep that ego to your advantage sometimes. Usually it's bad, but sometimes it can be to your advantage. And in between those complications, I think that's where it's good to just take a second, think about what should you have done differently, avoid it the next time, and then move forward.
And to be honest about it, how much of that type of debrief, when you do it in a situation like this, how much of it is truly constructive and how much of it is a little bit of just beating yourself up for something that maybe you could control, maybe you couldn't? What's it like for you?
Yeah, I mean, you definitely beat yourself up. I think I don't. I'm decent about beating myself up later in the day. Not during the middle of the day, but like I, for example, have a text thread still with all of my co-fellows from 8 years ago. And it's kind of like our confessional. Like anytime we have a problem, we go and we have confession where we're like, hey, look at this shit I just did. Like, I'm an idiot. Like, would you guys have done anything differently? And it's a nice way to just be like, okay, wipe your hands clean. Like I told someone about this, like it's going to be okay now. So I think having that support network wherever you get it is good. Like I have good partners as well that I can do that with. But if you're by yourself and you have no one to kind of share this with or kind of talk it through like afterwards, I think that's where you can get into trouble.
Yeah. Yeah. That's interesting. I've heard the confessional story from a few other people. I think this is a rich area to explore at some point. Well, Jeff, thank you so much for sharing this case. Thank you, quite honestly, for what you did for the patient. She, as miserable as it might have been during the case itself, it looks like things have gone okay for the moment. I hope when she shows up for her next visit, there's nothing about pain listed on the on the reason for the day's visit. But and thank you for being honest and sharing this case with our listeners. I really appreciate it.
Yeah, of course. Thanks for having me. This is, as we mentioned before we came on, a little bit cathartic to go through it again. But yeah, these are good. I think it's good to share these bad outcomes. Like we do thousands of these that work really well. Hip surgery is amazing, but yeah, you're always going to get these if you do enough of them, I think.
Thank you for joining me for this episode of the AHF podcast. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy and healthy and fracture-free